Welcome to the class of Pediatrics Kids Covery. Myself Dr. Parv, and we are discussing the topic of pediatric endocrinology. The topic of discussion is congenital hypothyroidism. So see this baby, she is having a protruded abdomen, a protruded belly. Okay, can you see the belly is protruding out? She is having a scaphoid abdomen. Baby is having a tongue which is being protruding out, so he's or she is having protruded tongue. Okay, right? And if you see, there is no hair or less hair which is going to be there, sparse hair. This is something which we see in the case of people, the patients who are suffering from congenital hypothyroidism. Okay, so now if I ask you that, okay, you must have seen one or two patients who are suffering from congenital hypothyroidism, but can you tell me that what is the cause of congenital hypothyroidism in cute little children? The cause is actually thyroid dysgenesis. The cause is thyroid dysgenesis. What do you mean by thyroid dysgenesis? That means the child is not having the synthesis the child is not having the synthesis of thyroid gland. Okay, the thyroid gland is not able to synthesize the thyroid hormone. Okay, this is the most common one. What can be the others? Others can be anything, like one, synthesis issue. For example, it is synthesized normally, secretion issue. If not secretion issue, transport issue. If not transport issue, metabolism issue. If not metabolism issue, it is reaching to the site but the receptors are not stimulating, so resistance to the thyroid hormone. Okay, it can be because of the central problems as well, like the hypothalamic and pituitary issues, like hypothalamus and pituitary are not able to synthesize the adequate amount of TSH. And if the TSH is not formed, or even if it is formed, resistance to TSH, in both of these cases the child will have hypothyroidism. For example, if the mother is taking some anti-thyroid drugs, this is also a cause of decreased thyroid production, right? And the last but not the least is the iodine exposure. I'll come on to your iodine exposure, but I just want you to understand this thing very well, that the causes can be associated or can be remembered with a mnemonic cardia. C for central, A for antithyroid, R for resistance, D for disorders, A for iodine, and of course A for, you can remember, like antithyroid drugs. Okay, coming on to the iodine exposure, there are two phenomena, very important phenomena. Just remember that you have got Wolff-Chaikoff effect and Jod-Basedow phenomena. This was asked in INI-CET this year also. In fact, this is a very important thing which is being asked in various central institutions, vivas and university examination. What do you mean by Wolff-Chaikoff effect? So Wolff-Chaikoff effect is an inhibition of the synthesis of it's an inhibition of synthesis of thyroid hormone, which is caused by a sudden excess of iodine. Whereas what is Jod-Basedow, it is a hyperthyroidism which is precipitated by excess iodine in individuals with autonomous thyroid tissue. I mean, the thyroid tissue is autonomous, so if you provided excess iodine, of course there will be hyperthyroidism. Are you getting it? So there is an autonomous thyroid tissue which is there, so if you provide more amount of iodine, so it is going to be having the hyperthyroidism. So Wolff, just like the nature of the wolf eats up everything, so similarly Wolff has eaten up the thyroid. Similarly, you can remember, since it has eaten up the thyroid, there is inhibition of the thyroid hormone synthesis. Okay, whereas in Jod-Basedow is having a hyperthyroidism and excess of iodine because the autonomous thyroid tissue is present, and if you supply more iodine, it's going to increase. Okay, so actually what happens in Wolff-Chaikoff, of course in Jod-Basedow you are clear that excess iodine is actually a substrate for autonomous thyroid tissue to promote the thyroid hormone production. But what happens in Wolff-Chaikoff, dear friends, there is a high intrathyroid iodine temporarily blocking the organification of the iodine. I hope you know that conversion of iodide to I2 is called as organification. And if this step is getting blocked, how is this step getting blocked? See, it's a reaction in which iodide is getting converted into I2, and if you will supply a lot of I2, this is in turn is going to inhibit the iodide, in turn going to inhibit this reaction, and there will be no organification. Okay, so this is something which I wanted to teach you. Rest everything is an accessory inflammation, okay, information actually. So if you can remember, otherwise it's okay. So very simple, like outcome is going to be this inhibition, of course, is a transient inhibition. So this is a transient thing which is going to happen. But whereas in the case where we are discussing the Jod-based jaw, it's a persistent phenomena. It is seen, the Wolff-Chaikoff is seen in the normal thyroid glands, whereas if you talk for the Jod-based jaw, it is seen when there is an autonomous thyroid. Okay, there is an autonomous. So when will you see an autonomous thyroid? It is seen in the Graves' disease, autonomous thyroid nodule, multinodular goiter. Okay, so what is the clinical importance? So see, in this case, if you are using, what happens in some case, this phenomena is used. Like for example, if the patient is having thyroid storm, that means a lot of thyroid tissue had started developing all of a sudden. So what we do in that case, we give high dose iodine. Okay, we give what? We give high dose iodine. So once we give high dose iodine in the cases of thyroid storm, ultimately what is going to happen? There will be decrease in amount of thyroid synthesis, and whatever results we desire will be accomplished, will be maintained. Clear? Now, what is important for Jod-based jaw? There are some belts where iodine supplementation programs are run. If the person is having this problem, which is called as Jod-based jaw effect, please don't, some problems like multinodular goiter, Graves' disease, autonomous thyroid nodules, please stop giving iodine for them, because it is ultimately going to increase the level of thyroid in them. Okay, so very simple to understand that Wolff stops, Jod jump starts. So jump starts means that it is going to increase. So what are the symptoms at birth in case of patients who are having low thyroid? So there will be symptoms at birth. Why? Because mother is having a lot of thyroid, mother is having a lot of T4 that is going to cross the placenta, and that will be delivered to the baby. So at birth, majority of the patients are asymptomatic. Okay, asymptomatic. But if they are untreated, of course there will be neurological problems which are going to develop if the patient is having less thyroid. But what classic history will you see? Say because of hypothyroidism, the bile is also going to get accumulated. That's why there will be prolonged jaundice. There will be poor feeding in case of children. There will be constipation, because somewhere or the other thyroid hormone is responsible for the peristalsis also. So because there is constipation, there is poor feeding and prolonged jaundice which is going to occur. Now everything, see, I always teach like this, that if there is thyroid less, the BMR is less, the heat production is going to be less, everything is going to be weak, because the BMR is not there. So of course the oxygen is less, so everything is going to be weak. Okay, again BMR is not there, heat is not there. Okay, so the child is going to be cold intolerant. Then excessive cold. Okay, nowadays there is excessive cold in the northern states of India. So what is very common? Dry skin. Okay, everybody in the morning apply moisturizer, so dryness is going to be there, which is going to be seen in these patients. Okay, so these all things which you have to remember. See, hoarse cry, weak cough, slow respiration. Okay, everything is going to get slowed down. Okay, and the things which are going to give, so see, it is seen that if there is less thyroid, so what happens, that there is glycosaminoglycans, or you can say the mucopolysaccharides, or leave everything, some substances. Okay, some substances are going to get accumulated, some substances So all these accumulated substances are responsible for the abdominal distension, and if the abdomen is distended, there will be pot belly, there will be umbilical hernia which is going to be there. Of course, jaundice is going to be there. Of course, there will be decreased tone and constipation, and that's why there's poor feeding. And if the GAGs, the substances, they start accumulating in the tongue, there will be macroglossia, protruding tongue. There will be enlarged fontanelles which will be there. Of course, the dentition and the bone is not formed properly. Okay, and in these patients there is a flat nose, wide eyes. Okay, of course, dry skin and pale or the cool body. I have told you why. So wide eyes and flat nose will also be there. So can you see these eyes are wide, the nose is flat. Okay, so flat nose and wide eyes will be there. Wide eyes will be there. Of course, important thing, the bulging fontanelles will be there. Okay, bulging fontanelles will be there. Rest all the things I have told you, just for your revision, neurodevelopment is also hampered. So if you want to check for the levels of thyroid, on the very first day we do the heel prick. Okay, we prick the heel of the baby, heel prick test, and TSH level, thyroid levels, okay, TSH levels are also checked. So if it is a primary congenital hypothyroidism, of course the TSH is high. Why? See, the T4 levels are less in this case, and that is why TSH is high. But the problem is that even if TSH is high, there is thyroid dysgenesis which is there, and because of the thyroid dysgenesis which has occurred, there will be no T4 formation. There will be no T4 formation will be there. Okay, what is subclinical? Subclinical means, see, of course the T4 is normal. T4 is normal, so there will be no clinical manifestations. But whenever you will see the TSH level will be raised. So despite TSH is raised, T4 is not raised, it is normal. That means TSH is demanding the T4 to be raised, but it is still not raised. That means there is hypothyroidism which is there, but it is subclinical because there is no clinical manifestations which is there. In central, of course, TSH is less, so the T4 and everything will be less. So what we have to do, just you have to first of all check the thyroid function abnormalities. Okay, and enzymatic defects can also be checked, like sometimes the TPO enzyme is defective, thyroid peroxidase, so this also is important. So first imaging in the case of hypothyroidism is ultrasound, in order to check if the thyroid is there or not. Sometimes ectopic thyroid is there, thyroid is not present on its normal site, so of course normal synthesis is not going to occur. So first investigation is ultrasound. Second investigation is going to be radionucleotide uptake. Like for example, even if the thyroid is at its normal position, we have to check that if the thyroid is functioning or not. So radioactive uptake is responsible to tell you and which isomer you are going to use. So remember iodine 1, 2, 3. And how I used to remember iodine 1, 2, 3 for diagnosis. See, in first year, second year and third year, you just focus your reading skills on diagnosis. Okay, and in final year you generally learn about the treatment. So iodine 131 is actually about the treatment. 3 plus 1 1 is equal to 5. So fifth year internship is something which is related to your treatment. And then you have got the treatment goal. So what is the treatment goal? We just want the serum T4 to come into the normal range. So we give oral levothyroxine to the baby. Oral levothyroxine to the baby, and this is it for the congenital hypothyroidism. Thank you so much for watching.